Thank you very much for the invitation. I'm going to play the part of the consumer in this discussion, because as a medical oncologist, I'm looking for approaches that will improve patient outcomes. And I've had the privilege of watching this from the days before there was a PSA test in urology. That was the first thing we really had to deal with. And when people started to see these numbers, it was panic because nobody knew exactly what it meant. We didn't know which patients actually had active disease that might cause symptoms or result in death. And again, as people who are looking to treat people who need it, that's the first question you have to ask. Because if the patient's going to have something where just the blood test is going to get slightly higher over time, there's nothing that really needs to be done, except to monitor them closely. So here's my disclosures. So really think about it. What we're doing now, looking at diagnostics, is more like translational science. And unfortunately, that's a little bit underestimated in many groups. It's not quite the same as a laboratory, but in fact, it's the same type of questions. And really what we're looking to do is how do we make better decisions for patients? And that's really what this is all about. You can really put this into two categories. This is the diagnostic, really understand what needs to be done for a particular group of agents. Is it aggressive? What is its biology? Are there particular agents that you would use for that particular individual? So that's one portion. The second is how do we pick the treatments that are actually going to make the outcome for an individual basis? So if you think about it, what we're really seeing now is a rapid, marked increase in understanding the biology of an individual patient's disease. But what essentially has to happen, this has to be in a continuous assessment, not much different from infectious diseases. If somebody has a bacterial infection and it doesn't go away, you know that you're dealing with something that's more aggressive. And what we're starting to see now, as we have more treatments, we're actually changing the disease over time. And again, as this evolves, we'll be talking a little bit more about this later. In fact, we're dealing with tumors that are becoming more and more aggressive, for which we actually don't have real effective treatments. So again, how do we do this? Do we do biopsies? That can be invasive. I focus on prostate cancer. We're dealing with a lot of bone metastasis. It's difficult to get enough material to actually do a profile. But we also know that if you just do a biopsy, you're looking at one site. We do a lot of PET scans, and we can see ranges of glucose uptake or different levels of prostate-specific membrane antigen, which is a now new theranostic approach, which is approved. And you really start to have to think about each of these lesions as an individual patient. So if I'm looking at a patient, I say, where is the most serious area I have to focus on? If somebody has liver disease, that's going to be a lot more important than a lymph node in the pelvis. And what we're learning, again, with the liquid biopsy approach is that we can see a bit of the diversity because we have representations of different lesions within the individual site. And also what we're starting to understand is what's the environment? If you think about it, if you go looking for a house, you want a nice environment. Prostate cancer is like bone. And again, you'll see different areas. So all of these considerations have to be factored into it. Again, I ran the GU Oncology Service for 25 years, then was asked to set up a biomarker program because when I started, again, there was no PSA test. We had no way to measure how diseases ran. We started again in 2017, and you can see how things evolved over time. One was taking a test for ARV7, that's a mutation in the androgen receptors, which achieved a New York State approval as well as CMS. And we've continued over time to broaden the scope. And again, we have a large group now of different disease areas focused on this and thinking about how do we show utility. Thank you, Peter, for that discussion. Because really, if you think about it, if you have a certain amount of money or a patient, how do you optimally spend that money to make the best decisions and which particular approaches do you approve? So again, what we're dealing with now is a biomarker program. We have a lot of external collaborators, and again, it's really been, I would say, very, very enjoyable. And our mission is, again, is to accelerate the approval of these tests so as to improve patient diagnostics and outcomes. And you can see, again, the scope of the disciplines that are now working together, both in terms of our disease areas, as well as with individual treatment teams. Now, again, we're also now expanding beyond the realm. We're working again with the Bloomberg Group, trying to standardize how are things approved in different countries. Can these be very, very similar? You can see me again a little bit sitting in the second seat on the right. But again, the idea of doing this, just how do we start to understand different populations around the world, and how do we make these things variable and be consistent? So again, the first question I would answer, how did I meet Biodesix? It's a company that happens to be in Boulder, Colorado. Just so happens my son happens to live there. But again, it was at this meeting in the year 2000 when I was listening to my colleague to the right speaking about the use of proteomics, and what was particularly clear to me was that, in fact, the test assays that they were using were clearly validated. The performance was consistent, and also they had a clear clinical use focus of how these tests would be used. And getting a New York State approval and covered by CMS was really, they said, this group knows exactly what they're doing. And as I mentioned, my son and my daughter now live in Boulder. That's a sort of a bonus. But again, it was just seeing this level of performance, having looked at initially trying to do these type of tests with research labs, it just doesn't work, particularly if you're trying to take it in a regulatory path. So how is our structure? The first thing we focus on, what is the unmet need for a particular patient? How do we focus on what's the decision that we're trying to improve? How do we know that the assay is fit for the purpose that you want to use it? Again, many groups do not consider statistical designs. It's no good now just to publish a p-value. That means very, very little. And again, it's obviously this is can be quite expensive. So you want to do things most efficiently in order to have better decisions. At MSK, we have a very large center of molecular oncology for doing profiling. This group has been in position a little over 11 years now. They've done over 140,000 samples. All of these the group is FDA FDA approved. We have a group that will analyze it to say which treatments should be recommended, is there a particular drug for an alteration you might have found. We also have a concurrent MSK access test for self-read DNA. And again, thinking about prostates, we have about 5,000 cases. How do we think of this disease? We think of it in terms of what we call clinical states. Again, this is different points along the illness, and what we're looking to is follow patients along this continuum, beginning with localized disease, biochemical recurrence, metastatic disease before hormone therapy. And then we're starting to see over time, as patients are getting more treatment, first, second, third line, we are treating a completely different disease that we actually had never seen before. If you start thinking about the approvals, again, in red, you'll see that there are, these are the androgen receptor targeted agents, all approved. If you think about, we also have a group that are specifically have DNA damage repair alterations. Again, another set of drugs in green that have also been approved. I mentioned the theranostic approaches. Again, I think of this as inside-out radiation, which is actually quite effective. That was approved about a year ago. But if we start thinking about some of the alterations, what about checkpoint inhibitors? In prostate cancer, prostate is considered to be somewhat quiet, not really active. And again, if you start thinking about it, there's very few drugs that actually are formally approved specifically for prostate, except when you start thinking about microsatellite instability. Prostate actually was carried over it because the alteration was present. And in the first phase 3 trial, there was at most 1 or 2 prostate cancer cases. And this has been really, it's a relatively rare disease. So if we start thinking about it, how often do we see microsatellite instability? If we find it, in fact, almost half of the patients will respond. But if you look down, when we looked through over 2,000 prostate cancer, the frequency is only 2.8%. Similarly, for tumor mutational burden, again, these tumors specifically don't respond to the checkpoint inhibitors. Again, a very low frequency, which makes it very, very difficult in order to get the numbers to really understand what's going on. So the real question we started to ask, what about looking for potential protein predictors? And again, the first discussion I heard from Gary was talking about lung cancer, where there was a test approved, one, if there were small nodules in the lung, were these malignant or not, and what was the probability of response to a checkpoint inhibitor. So again, as our first research plan in collaboration, which I call kicking the tires, we're trying to get a little bit of a handle on the types of patients that we could be seeing, understanding what's going on them in terms of what proteins might be there. And again, can we start to think about identifying how well the tests that they have for understanding the checkpoint inhibitors will have applied to the same degree to patients with prostate cancer? We don't know that as yet. The other thing we're going to start looking at, we have a large bank of samples. Will there be a difference between plasma and serum with this particular group? Obviously, this makes it a lot easier to do. And this is one of the first questions we want to know, because we have to make sure that we're getting the right specimens if we're trying to answer the right answer. So again, going forth in terms of looking for sensitivity to checkpoint inhibitors, we will be testing the approved test that you'll hear more about shortly, the Veristat. We'll be going further, looking at, is there a relationship between response, as they've shown in lung cancer, in the same this and other diseases. We'll be looking also at the comparisons between sera and plasma, and what particular regions and what are the size of the proteins that they will be looking at, and also start thinking about, are there other markers of inflammation in general that might also be helpful in terms of developing this result. For the second, we're going to be looking a little bit more into the serum plasma question, and again, expanding it into the later stages of disease, where we start seeing lineage plasticity and transformation of the tumor, in part because it has survived the multiple treatments to which it has been previously exposed. And if you look here on the left, you start to see the newly diagnosed patient, very responsive to hormone treatment most of the time. As we start getting into the castration resistant, we're using the new AR inhibitors. As we go further, you see the change in therapies and classes of drugs that are utilized. And what you start to see again is, even after immune suppression, there'll be reactivation in the androgen receptor, but then many of these tumors become AR independent and very, very difficult to treat. So understanding the changes that have occurred at this point is really a problem. And if you again look here, you notice the different frequencies of the different classes of alterations that are present. Last, looking at this on a histologic point of view, you can see on the top the small local, the small cells together, and they're endocrine, positive for synaptophysin, which you generally don't see, whereas within the same tumor, you also have the adenocarcinoma component, as well as positive staining with PSA. So again, we'll also be looking, can we identify new biomarkers using proteomics for lineage plasticity? Again, in the small cell lung cancer, the dominant becomes increased activation of the epidermal growth factor receptor. We'll also see in other cases, been very common in prostate cancer, is RB1 loss, often associated with other changes, which will including PTEN loss and P53. And as you notice, these become more and more neuroendocrine. And again, within different tumor types, we see different classes of this transformation. In addition, another disease where there is activity of checkpoint inhibitors we'll be looking at bladder cancer, so again, to see how this too can predict ahead of time patients who have tumors that might specifically benefit for this, and see if they're saying the same effect that they have in lung cancer on progression-free survival as well as overall survival. So again, I'm very privileged to work with a very strong group of people. Notice the range of disciplines that are working together. And now I'd like to pass the chair to Gary.
Thank you, Howard, for the introduction. I think it's safe to say we're going to be busy for a while. I think one of the things that Howard maybe didn't mention in our meeting, but 4+ years ago now, Howard, was sort of the philosophic match between the institution, MSK, and how Biodesix approaches test development. So today, I'm playing the role of test developer. Jonathan and I go back a long, long way. Previous to my 12-year now tenure at Biodesix, I actually had a 10-year tenure at Ventana and Roche, where probably I learned a lot of how to approach these things with collaboration in mind and joint and shared goals. So as I came to Biodesix, liquid biopsy, as you can imagine, was in its very, very earliest stages, right, 10 years ago. Except this company had been doing proteomic, clinical proteomics for much longer than liquid biopsy, the term probably had even been around. At Roche, we had premiered EGFR testing in blood with PCR, as you know, and this was as much as we knew about liquid biopsy. But today I'll introduce how we're marrying proteomics with genomics and then how that collaboration intersects with what we're doing with Memorial and Howard and team. So Biodesix, briefly, the only word I want to touch on here in our mission statement is delivery of rapid results. And that can be from genomics, it can be from proteomics. Our focus today is in blood, but I think one of the topics we'll talk about in the panel is challenges in developing liquid biopsy tests. And I'll talk about our journey through tissue to get to a blood-based assay, because there is no blood-based assay many times without a tissue assay accompanying it. Two core businesses, briefly, I'm paying the bills here. Howard talked a lot about what we do on market on the left in our lung diagnostic tests. So these are now 5 Medicare and other payer approved tests on market, which are all also New York State CLEP approved. And then on the other side, you can talk to our services team here, whether it's working with biopharma or other diagnostic companies. We yesterday announced our relationship with Memorial, but also with Bio-Rad. So we have significant partnerships as well with diagnostic companies. So our BD team is here, I don't know whenever the exhibit hall opens, but you can talk to Matt and Michael about that side of our business. We actually operate 2 highly certified clinical laboratories to support our tests, whether they're commercial, in the sense of the commercial clinical tests or the biopharma diagnostic services. Both are equivalently certified. So they're all CAP-CLIA ISO 13485, as well as New York State approved, different approval CFQ, if you will, depending on the laboratory. And myself, the New York State lab director in our corporate lab, recently moved to Louisville. Howard mentioned we were previously in Boulder. So we just completed that move to our new facility at the end of January this year. This is where, I think Peter showed slides, proportion of patients through the journey of cancer. Here, this is a graphic from a review recently showing ctDNA. You could as well add other markers, but from left to right, really a patient's journey through oncology. This is also showing the journey through lung cancer. And the interesting thing for me is the role of blood-based diagnostics, because along the bottom, what you see are a whole host of blood tubes. So we know in part why liquid biopsies become more and more clinically relevant. It's non-invasive nature. So sampling along the continuum of care is where Biodesix really sees continuing making a difference. Talked about partnerships, and Howard and I, as I said, got together just before the pandemic and continued our discussions throughout the pandemic, and have now put together multiple types of agreements to govern our work. One instance includes a partnership, though, with Biorad. We've had as long a collaboration with Biorad, I think, as I've been at Biodesix. We've also done various things with Thermo Fisher, both on the proteomic as well as genomic side, and others. We continue to look for strategic partnerships to enable our tests, either in development or commercialization. So I'm also happy to discuss how we can partner. Our focus in liquid biopsy, as I said, is not only tumor-centric. It's tumor, but it's also host. And I think this is one of the things we agreed on, Howard, that was differentiating about Biodesix. We sampled the immune system in the context of cancer before anyone else was doing it. It didn't start when I got to Biodesix. This has already been in work in progress, but I'll share data from today, how we continue to look at both sides, if you will, of this equation. It's complex, it's difficult, but trying to put the two sides together with multiple tools and technologies is really what we're focused on. This is realized 5 on-market tests currently in the United States. The first one discovered actually in 2004. And then recently, with various acquisitions, we've commercialized additional tests, whether it's in nodules or in later stage disease. So what does that look like in terms of impact? These are the clinical proteomics tests. I just pulled these data before this meeting, so it represents different sites across the United States that have received our proteomic tests. So 3 of those tests have 3 different technologies underlying them for the conduct of proteomics. On the genomic side, 2 different technologies underlying the 2 approved tests, where we have ddPCR through Biorad collaboration, and then NGS and another collaboration with Thermo Fisher. But again, map showing where our tests have made impacts across the United States. How do we then, as the test developer, fit into the framework? With Memorial, Howard laid this out as well. This is a different view of where Biodesix sort of is in the middle. Our entire focus and role is in test development, getting that test on market and reimbursed. With Howard and team, we've got the clinical experts who understand the clinical questions, who see the patients, and we can lean into the kinds of questions that investigators within the biomarker program are asking. Our goal and focus is then putting together test development best-in-class technologies together with practices and how we get these tests on market and commercialized. Additionally, and we'll talk a little bit more about this as well, the role of consortia. So we've also been very, very active as others in the Friends of Cancer Research initiatives, which brings tremendous regulatory insight, how we pursue these things more broadly. What are others doing? How's FDA view risk with some of these tests? So BloodPack and others are obviously consortia that many of us participate in. Test development, now I'm not showing every technology and platform we use. I mentioned 5. This happens to be very, very focused and centric on what we're doing with MSK today, so genomics as well as proteomics. But our central mission is getting more answers out of that one blood tube. In terms of pipeline and the kinds of questions we're looking at, so it includes risk of recurrence. Primary immune response, not going to spend a lot of time on that today, but of course, because of what we do and the sensitivity of the tests that we're looking at and monitoring as well, the immune response and the tumor minimal residual disease. I've done this many, many times, and I've shared this slide as a part of education and how to go about test development. This is a process that we follow. It blends New York State oncology guidelines. It blends FDA and other guidelines in terms of how to develop and validate many tests, but including liquid biopsy. So I'm happy to discuss how we do this. What are we doing with MSK? So Howard outlined some of the projects specifically. So this maybe takes it up a little bit more or in depth, if you will, to some of the disease progression recurrence projects, including minimal residual disease, where we're partnered with Biorad, as I said, and have done work to bring an ultra-sensitive, very, very rapid droplet digital PCR plasma-based assay to market. We've been working with Biorad, like I said, for a long, long time, and now we've taken this to another level. With MSK, we've got a very productive collaboration. It's been going on for several years now. And then our work internally, and then with Biorad, where we'll share more data at AACR. But just to give you a snapshot, because again, I'm a scientist, so I love data. This is what a if you will, 6-color, 7-plex on a Biorad droplet digital PCR with the new highly sensitive chemistry looks like. So we can get sensitivity as low as 0.005%, or about 1 to 2 copies. Peter talked about sensitivity versus specificity. So if you drive down to these levels, you can imagine that you're going to give up some specificity in going for sensitivity. And these are questions that we're going to work through in the clinic. There's a different view as you look forward to 3D view of doing this. But on the proteomic side, Howard didn't share this data, but we'll share it in an upcoming meeting. So this is looking at metastatic castrate-resistant prostate cancer sampled with one of our proteomic tests, the VeriStrat test, and you can see the difference monitoring the immune system as well can have. So VeriStrat good, so this is prognostically good. Median survival, 633 days versus, again, pre-treatment VeriStrat poor, median survival of 130 days. So conclusion, host immune profiling test can as well accurately stratify metastatic castrate-resistant prostate cancer patients, on this case with abiraterone or enzalutamide, into good and poor groups. I'd like to thank you and our team for your time. Look forward to the next session.
Thank you, and Gary. We've got a little bit of time for 1 or 2 questions. If we had someone from the audience who's interested in asking a question for them.
Hi, I'm Meredith Osborne with Discovery Life Sciences. One of my responsibilities is managing our biobank. And I'm curious, how did you acquire tissue samples from metastatic castrate-resistant prostate disease? That's one area where I know there's research need, and we internally have a lot of trouble sourcing tissue. Blood is easy to get comparatively, but I'm curious if you could speak to that, obviously knowing that tissue is needed for the test development.
So it's fairly routine for us because we understand. Actually, this started before we got into the cell-free. We do a lot of PET scans. We can identify lesions which appear to be new or more aggressive, and those are the ones we obviously try to do so. We have a group of radiologists who are experts on doing these biopsies, and we have a meeting every Tuesday morning where we go through them in order to understand to see which one can be safely obtained. And also then it's, stored appropriately depending on what assays you want to use and when. So it is a routine for us because to know we've seen these changes over time relatively slowly, and they're becoming even, more aggressive. And the good news is more actionable. And that's, again, that's really why we're doing it, to see how can we change it. If his liquid tests will give us similar information, then obviously we'll take it. And those have become much more sophisticated. The first one I did with a company that I won't name, we sent 40 samples. We had 3 mutations in the whole group. That was a long time ago. Now you're seeing not only what it is, but you're getting a sense of, how much of it, which is also relevant. And again, with the OncoKB, that's really the gold mine, because there's no way you can interpret these profiles. And there's a group that will say, okay, this is a drug for which there is it's ranked on 1 to 5. 1 means there's an approved drug for a mutation for that disease. Number 2 would be there is a mutation for which there is a drug, but not necessarily for your disease, et cetera. So that makes it very helpful. Or you could say it another way, we're spoiled.
So I had one final question for your presentation. This is to Howard. So Memorial Sloan Kettering kind of acts a little bit like a diagnostic development company. You have MSA ASCUS you talked about. How does your group decide whether or not this is something you should try and build internally with your capabilities, or do you leverage experience and the capabilities of a diagnostic partner? I'm sure MSK doesn't have a MALDI-TOF in order to do diagnosis for
no, we realize we can't do everything, and obviously it's a matter of scale and capabilities. I think one example is our collaboration with Biodesix, that we have a group that is doing some work on proteomics. They can't do it to this degree of scale, can't turn it around as quickly. And again, if you look at the numbers of samples you need to do these kinds of analyses, it's enormous. So you have to be realistic. It is becoming more problematic. Now we're getting into, whole genome analyses. We can't do that at scale. We are still, again, it's space, people, and, we do what we can, but it can't go on forever.
Great. And thank you once again to our presenters, Gary and Howard. And now we're going to move on to our panel discussion for this one. I'd like to invite up Nick Dracoli, who's the Chief Scientific Officer from Delphi Diagnostics. And this panel is titled Clinical Adoption of Liquid Biopsy Diagnostics. I'll be moderating the questions, and then we'll save some time for the audience. But we endeavor as a panel, as a group, to make this the second best presentation you're going to see today after the fireside chat with our speaker about AI later on today, as you're well aware.